Hello everyone, this is Anthony Chan. Welcome to the sixth lecture of my lecture series on essential medical liver pathology for trainees and any pathologists interested in liver pathology. In the previous two lectures, we discussed various patterns associated with hepatic and cholestatic injuries. The upcoming section will explore the significant histological patterns linked with steatotic and vascular injuries. Let's get started on the steatotic injury. The first pattern is the steatotic pattern, which may more accurately be referred to as the macrovesicular steatotic pattern. It is characterized by a mild to severe degree of macrovesicular steatosis. Lobular inflammation can range from absent to mild, and ballooning degeneration should be absent. Fibrosis varies but often begins with perivenular and pericellular fibrosis. Macrovesicular steatosis with a classical large droplet of fat is present. This is an example of macrovesicular steatosis with mainly small or medium droplets of fat. Spotty necrosis and mild lobular inflammation could be present in the steatotic pattern. Another example shows a focus of spotty necrosis in the background of macrovesicular steatosis. It is important to emphasize that steatosis with lobular inflammation is not equivalent to steatohepatitis. Perivenular and pericellular fibrosis is characterized by delicate fibrous strands deposited around the central vein, extending into sinusoids and appearing to wrap around hepatocytes. This type of fibrosis is typically observed in fatty liver diseases but may also be seen in uncommon conditions such as congestive hepatopathy, Budd-Chiari syndrome, and sinusoidal obstruction syndrome. It is generally not observed in other chronic liver diseases. Pericellular fibrosis can still be evident in the cirrhotic liver and may serve as a hint of underlying fatty liver disease. The major differential diagnoses of the steatotic pattern are alcohol-related liver disease, metabolic dysfunction, associated steatotic liver disease, chronic hepatitis C, drug-induced liver injury, and Wilson disease. This table highlights different medications and toxins associated with macrovesicular steatosis. Mild steatosis is typically observed in chronic hepatitis C, particularly with genotype 3. In addition to steatosis, there is usually portal lymphocyte-predominant inflammation, mild bile duct injury, and bead-like sinusoidal lymphocytic infiltrate. However, if more than a mild degree of steatosis is observed in chronic hepatitis C, other causes of steatosis should be investigated. This is a gross autopsy photo of markedly steatotic liver from a patient receiving high-dose steroids. This is the corresponding histological photo showing the steatotic pattern. Compared to the steatotic pattern, the steatohepatic pattern is characterized by the presence of ballooning degeneration. Mallory-Denk bodies are often found in these balloon hepatocytes. Ballooning degeneration is characterized by cellular swelling of the hepatocyte, rarefaction of its cytoplasm, and the presence of clumped strands of intermediate filaments. It is the histological hallmark of steatohepatitis. Another example shows prominent ballooning degeneration. Some ballooned hepatocytes contain deeply eosinophilic, ropey intracytoplasmic inclusions known as Mallory-Denk bodies. These bodies consist of misfolded and aggregated intermediate filaments, mainly cytokeratin 8/18 and proteins such as P62 and ubiquitin. Alcohol steatohepatitis and metabolic dysfunction-associated steatohepatitis are two major causes of the steatohepatic pattern. It is also important to consider drug-induced liver injury and Wilson disease as potential causes. This table provides a list of medications associated with steatohepatitis. This is an illustrative example of methotrexate-induced steatohepatitis. Methotrexate is a widely used chemotherapeutic and immunosuppressive agent. Patients receiving long-term methotrexate therapy may develop hepatic steatosis, which can progress to steatohepatitis and hepatic fibrosis. Regular monitoring of liver function tests and liver biopsies may be necessary to detect and manage methotrexate-induced liver damage early. Wilson disease can present with a steatohepatic pattern. Features such as steatosis, ballooning degeneration, Mallory-Denk bodies, and glycogenated nuclei, typically seen in alcohol steatohepatitis, and metabolic dysfunction-associated steatohepatitis, can also be present in Wilson disease. The accumulation of copper and copper-associated proteins in a liver biopsy, particularly with no fibrosis or early fibrosis, or the presence of steatohepatitis in a young patient with neurological symptoms, should prompt consideration of Wilson disease. Correlation with serum ceruloplasmin levels and further confirmation by genetic testing are necessary. You might have noticed that I haven't used the terms non-alcoholic fatty liver disease and steatohepatitis in most of the slides in this series. Instead, I refer to them as metabolic dysfunction-associated steatotic liver disease and steatohepatitis. These updated terms have been adopted since 2023 and are supported by over 70 professional organizations. This change aims to reflect the underlying pathophysiology better and to avoid the potentially stigmatizing terms non-alcoholic and fatty. If you're interested in learning more about the evolution of this terminology, please click the video link in the upper right corner. Determining the underlying cause of steatosis or steatohepatitis in a liver biopsy can be challenging when a patient has both a history of alcohol consumption and metabolic risk factors. Histologically, both conditions are nearly indistinguishable. However, alcohol-related liver disease may present with certain rare but specific features such as acute foamy degeneration, sclerosing hyaline necrosis, cholestasis, and sinusoidal obstruction syndrome. We now have an improved approach with a comprehensive terminology for steatotic liver diseases, focusing on alcohol consumption and the presence of metabolic risks as key factors. For patients with steatotic liver disease and concurrent metabolic risk, alcohol consumption under 20 grams per day for women and under 30 grams per day for men is considered insufficient. These patients will be classified as having metabolic dysfunction-associated steatotic liver disease MASL. If alcohol consumption is excessive, specifically over 50 grams per day for women and over 60 grams per day for men, these patients will be classified as having alcohol-related liver disease, regardless of the presence or absence of metabolic risk. A new category called metabolic dysfunction and alcohol-related liver disease method has been created for patients affected by both metabolic abnormalities and substantial alcohol intake. Among other steatotic liver diseases with specific etiologies, monogenic diseases include Wilson disease, lysosomal acid lipase deficiency, and other inborn errors of metabolism. Examples of miscellaneous causes are chronic viral hepatitis C, HIV, malnutrition, and celiac disease. Diffuse microvesicular steatotic pattern is a distinctive steatotic injury completely different from the steatotic and steatohepatic patterns. As mentioned in the previous lecture, diffuse microvesicular steatosis is associated with significant mitochondrial dysfunction and fatty acid oxidation defects, as seen in conditions such as Reye syndrome, acute fatty liver of pregnancy, acute alcoholic foamy degeneration, and urea cycle defects. Although Reye syndrome is the prototype condition associated with diffuse microvesicular steatosis, several medications can also lead to this histological pattern. Notably, certain antiviral drugs, such as nucleoside reverse transcriptase inhibitors like sidovudine and didanosine, are well documented for causing microvesicular steatosis. These are significant underlying causes associated with patients experiencing clinically fulminant acute hepatitis or acute liver failure. Depending on the epidemiology of various countries and regions, acute hepatotropic viral hepatitis accounts for up to 68% of cases. Paracetamol toxicity is responsible for up to 43% of cases, while non-paracetamol drug-induced liver injury accounts for up to 32%. In up to 32% of cases, the cause remains unknown despite thorough investigations. Although liver biopsy is not routinely performed on all patients with fulminant acute hepatitis or acute liver failure, if it is done on some of these patients, we can expect to encounter one of three major histological patterns: acute hepatitic pattern, acute hepatic necrotic pattern, and diffuse microvesicular steatotic pattern. Each pattern provides valuable insights into the underlying etiology and helps guide the clinical management of these critically ill patients. Hepatic vascular disorders encompass a broad spectrum of conditions affecting the liver's blood vessels, including the portal veins, hepatic arteries, hepatic veins, and sinusoids. These conditions are relatively rare and often present significant diagnostic challenges. Typically, these disorders are diagnosed through clinical assessment and radiological imaging, which provide crucial insights into the vascular abnormalities. Liver biopsy is rarely required for diagnosis. It is usually reserved for cases where imaging and clinical findings are inconclusive or when there is a need to rule out other coexisting liver pathologies. Although I worked at a tertiary referral center and university hospital, hepatic vascular disorders represent almost 1% of my archive. Due to their rarity, histological diagnosis can be challenging. While vascular injuries can be categorized based on the affected vascularization, I provide a simplified approach by presenting relatively common and distinctive morphological patterns here. The first pattern is sinusoidal dilatation with or without congestion. A typical example of sinusoidal dilatation is a sinusoidal lumen that is more than one liver cell plate wide. This is another example of extensive sinusoidal dilatation involving different hepatic lobules. Hepatic sinusoidal dilatation can result from several conditions that interfere with normal liver blood flow. These include hepatic outflow disorders, such as those affecting the hepatic vein like Budd-Chiari syndrome, and post-hepatic systemic venous system issues, such as congestive hepatopathy. Sinusoidal obstruction syndrome (SOS) is another cause, where damage to the sinusoids impedes blood flow. Portal sinusoidal vascular disorders, which affect the portal vein, also contribute to sinusoidal dilatation. These conditions are usually accompanied by other histological features helping the diagnosis. Additionally, certain medications and toxins can directly affect the liver's vascular structure, leading to sinusoidal dilatation. Oral contraceptive pills are one of the most common medications associated with sinusoidal dilatation. Zone 3 hemorrhagic necrosis with sinusoidal dilatation and congestion is commonly seen in acute hepatic outflow disorder, which also falls into the differential diagnosis of acute hepatic necrosis pattern mentioned previously. Hemorrhagic necrosis, characterized by significant hepatocyte dropout and the presence of edematous hemorrhagic connective tissue, is found in acute hepatic outflow disorder. Sinusoidal dilatation and congestion are commonly seen in hepatic outflow disorders. In cases of acute obstruction, red cells may extravasate into the space of DC, which lies between the endothelial cells and hepatocytes. However, identifying this feature requires a keen eye and sometimes a bit of imagination. In long-standing cases, fibrosis of the central vein can be observed, as shown in this example. Pericellular fibrosis can also be found in chronic hepatic outflow disorders. Obliteration of the central vein and zone 3 hemorrhagic necrosis are characteristic features of sinusoidal obstruction syndrome (SOS), which is strongly linked to exposure to chemotherapeutic agents, radiation, and specific toxins. Additionally, it's important to remember that SOS is also a differential diagnosis for the acute hepatic necrotic pattern. Acute hepatic necrosis in a case of SOS is demonstrated here. An example of SOS is induced by a chemotherapeutic agent doxorubicin. Nodular regenerative hyperplasia, which will be discussed soon, is another histological feature of SOS. Fibrous obliteration of the central vein can be identified in chronic SOS. Similar to chronic hepatic outflow disorders, chronic SOS may also exhibit perivenular and pericellular fibrosis. In an appropriate clinical context, you could diagnose SOS with 2 of 4 key histological features: sinusoidal dilatation, central vein occlusion, perivenular and pericellular fibrosis, and nodular regenerative hyperplasia. This table lists medications associated with SOS and Budd-Chiari syndrome. Unlike sinusoidal dilatation, peliosis is characterized by cystically dilated, blood-filled spaces resulting from rupture of the sinusoidal wall. There are cystically dilated blood-filling spaces, typically without endothelial lining. However, re-endothelialization may occur in those long-standing cases. Although the exact pathogenesis of peliosis hepatis remains unknown, it is associated with certain medications, infections, and chronic debilitating conditions. These medications are associated with peliosis. Nodular regenerative hyperplasia (NRH) is characterized by the widespread transformation of normal hepatic parenchyma into multiple small regenerative nodules without significant fibrosis. This condition arises due to alterations in hepatic blood flow, leading to ischemia, subsequent atrophy, and regenerative hyperplasia of hepatocytes. NRH is best visualized at low magnification in an excisional specimen. There are multiple nodules of hepatocytes. Please note that the steatosis observed in the background of this example is not associated with NRH. Serious red stain confirms the absence of fibrous septa surrounding those nodules of NRH. The reticulin stain not only demonstrates the absence of fibrous septa, but also visualizes the atrophic hepatocyte cords at the periphery of the nodules. NRH is associated with a wide range of conditions. If the patient doesn't have any systemic disease, major considerations include drug-induced liver injury, sinusoidal obstruction syndrome, and portal sinusoidal vascular disorder. These medications are associated with NRH. You might encounter the term idiopathic non-cirrhotic portal hypertension, which is characterized by portal hypertension in the absence of cirrhosis or advanced fibrosis. Due to the heterogeneity of causes and histological findings, numerous terms have been used to describe this condition. Some patients exhibit the same clinical and histological features without portal hypertension at the time of diagnosis. To better reflect the abnormalities in the portal and sinusoidal vasculature that lead to increased resistance to blood flow through the liver, a panel of experts proposed a new term, portal sinusoidal vascular disorder (PSVD), in 2019. The so-called portal vascular abnormalities here refer to the histological changes associated with PSVD. Here are the diagnostic criteria for PSVD. By definition, the diagnosis of PSVD requires a liver biopsy. Histology is crucial for excluding cirrhosis. Please note that portal vascular abnormalities associated with PSVD are unevenly distributed, vary significantly in severity, and can be very subtle. Not all lesions are necessarily present in a single case. Hence, the identification of portal vascular abnormalities is challenging. In addition to portal vascular abnormalities, nodular regenerative hyperplasia, incomplete septal fibrosis, non-zonal sinusoidal dilatation, and pericellular fibrosis are also associated with PSVD. Unfortunately, the terminology and definitions for these portal vascular abnormalities are ambiguous in the literature and textbooks, adding to the complexity of the clinical pathological scenario. The ELVS group, an international study group of liver pathologists and hepatologists, sought to reach a consensus to standardize the nomenclature for these portal vascular changes. Since the diameter of a normal portal vein branch is typically at least 3 times larger than that of the bile duct, comparing their sizes within the same portal tract can help identify a narrow portal vein. If the caliber of the portal vein is similar to or smaller than the bile duct, it indicates portal vein stenosis. Portal vein stenosis is also known as obliterative portal venopathy, phlebosclerosis, portal vein obliteration, and hepatoportal sclerosis. A herniated portal vein refers to a portal vein from the portal tract that directly abuts the periportal parenchyma. In the literature, it has also been known by terms such as hepatoportal sclerosis, aberrant vessels, and shunt vessels. A hypervascularized portal tract is characterized by the presence of multiple vascular profiles with thin walls and lumens of varying calibers. It is also referred to as fragmentation of portal vein radicals, portal tract angiomatosis, angiomatoid lesion, or angiomatous transformation of the portal tract. Periportal abnormal vessels are single or multiple thin-walled vascular spaces of different calibers located outside but adjacent to the portal tract. These vessels are also called aberrant vessels, cavernous transformation, paraportal shunting vessels, or megasinusoids. Don't worry if you're feeling confused about portal sinusoidal vascular disorder and its pathological changes. It is a rare condition that requires you to seek help from a liver pathologist to solve such a challenging case. Thank you for staying with us through these 6 lectures, exploring the most important pathological changes and histological patterns in liver pathology. It's been a fantastic journey of learning together. But the excitement isn't over yet. In our final lecture, we'll dive into the intriguing I don't know pattern. This topic showcases cases that challenge even the most experienced pathologists, offering unique insights and strategies for navigating diagnostic uncertainties. We appreciate your dedication to enhancing your knowledge and skills. If you've enjoyed these lectures, don't forget to subscribe and leave your comments below. Your feedback helps me create even more engaging content for you. Let's get ready for an exciting finale. Stay tuned and see you in the next lecture.